I know Dr. Gorthi for a very long time. He's well known in the field of stroke neurology. Now, Dr. Gorthi, please start
Okay,
your.
right. Good afternoon, everybody. Am I audible clearly?
Yes, sir.
Yes,
Yes.
sir. Yeah. So after, thank you, Dr. Vineet. You made my job very easy. And out of the cryptogenic stroke, which is shrinking, also eases from that. I am still focusing on the patent foramen ovale. What is patent foramen ovale and embryology and it a bit we discussed. Then, if so, if it is there, has it got role in ischemic etiology? Thus, if so, what are the possible stroke mechanisms? If so, how to diagnose and prognosticate? So there are so many questions. If it is found and you are suspecting, how to intervene, what is the evidence, case reports, case control studies, cohort studies, RCTs, SR, NMA, if it exists. If so, how to identify the suitable candidates for intervention and what is the rope score which we use to do that? If so, medical intervention is better or is it a closure devices which are better? Where do we stand as far as evidence is concerned? And I end by giving some key points and current guidelines in the algorithm and I conclude my talk. So as all know that it's a fourth week of gestation, the two atria separated by septum primum, but for a small hole called ostium primum. As the septum primum grows, the ostium primum is reduced in size and slowly disappears. The blood that is returning from inferior vena cava in the its oxygenated blood, it produces an excavation in the septum primum forming the ostium secundum, and this oxygenated blood goes to the other side, left side. The septum secundum grows all along the right atrial wall around the ostium secundum. These are the embryological wonders which we know. The septum secondum, you can see the fossa ovalis, and we are not going much into that. So the right atrium to the left atrium to the foramen ovale, the blood flows. At birth, what happens is the lungs function. The pulmonary pressure rises. The left atrial pressure is more than the right atrial pressure, so blood flow reverses and foramen ovale closes. The septum primum is pushed against the septum secundum and both fuse to form fossa ovalis. But in 25% individuals, it may persist and which may be responsible for paradoxical embolism. The prevalence of this in general population is about 25%, and the median diameter, if it exists, is 5 millimeters plus minus 2.6, and very rarely it can enlarge on the follow-up. The difference between a benign PFO and a pathological atrial septal defect of ostium secundum is the size of the hole, and which we'll see in the diagrams here, and the presence or absence of a flap of septal tissue and the size of the interatrial shunt. So these are the important issues. So if you, the most importantly, it is an echo diagnosis. The subcostal view can showing a 2.4 mm PFO in this case. This is a 2.4 mm PFO in this case, which you can see. The color Doppler demonstrating a left to right to left or left to right here, left to right here in the adult. So what are the associations? The by and large, the association is paradoxical embolism, and which causes cerebrovascular accident. TAS, and as Dr. Vineet is saying, is a small infarct, and it can lead to brain abscess. And migraine is also associated mostly with PFO because of hypoxic blood, or it could be because of microemboli. And a Caisson's disease or decompressive sickness and platypnea and orthodeoxia syndrome, where the individual becomes hypoxic on sitting posture. These are some of the associations, but we are going to talk about the atrial septal defect and the PFO, which will give rise to embolic stroke. And the most important thing is the excursion of the atrial septum. The excursion distance for atrial septal aneurysm is shown here. It should be only 10 millimeters, and more than that is going to cause a problem. This is the distance which is given in the literature. It's an as you know, it's an embryonic defect in the interatrial septum, but it may or may not be associated with aneurysm. If it is associated with aneurysm, it becomes high risk atrial PFO, and that is defined as a PFO that has a 10 mm or greater excursion of the septum. The PFOs are usually clinically silent, although they are associated with stroke. As said, some the Mattel in 2010 said that 38% of people with cryptogenic stroke had a PFO. The causal relationship is again a controversy. So the cryptogenic stroke we just heard is entertained when the stroke etiology cannot be attributed to any specific cause after an extensive search. The lacunar stroke secondary to hypertension, diabetes, intracranial or extracranial vessel stenosis, vessel wall dissections, and left atrial and ventricular thrombi, aortic blockage have been dealt just now, but uncertainty of etiology exists 30 to 40% cases. A significant number of these are embolic in nature, and all possible sorts of arterial embolism are to be investigated. And when we do this, we go take a recourse to transthoracic echo, transesophageal echo, transcranial Doppler, and where you can saline contrast injection can be given, and circulating cerebral microemboli, which produce a characteristic visible and audible high intensity signals of short duration within the transcranial Doppler frequency in the middle cerebral artery between 4 to 20 seconds. So there are various methods if you suspect this, and the most important of them is contrast echocardiography performed with agitated saline prepared by hand agitation of the saline between two 10 ml syringes connected to a three-way tap. Approximately 10 ml saline should be rapidly injected from one syringe to the other. I'll show you the diagram. The contrast should be injected immediately after preparation. The micro air bubbles too large to cross the pulmonary vascular bed, they cause the opacification, which you can see the right atrial opacification here. And if this is one of the things, if they are able to go to the left side, this can be 3 microbubbles pass from the right atrium to the left atrium within 3 cardiac cycles of the right atrial opacification. You can diagnose the shunt, and this shunt can be graded by the number of the bubbles which can cross to that side, the size, and this is grade 1, grade 2, and grade 3. More than 20 bubbles means it's a large shunt. So the cryptogenic, we are not going to the details. And what is this paradoxical embolism? The paradox, of course, is the appearance of a venous source thrombus in the arterial circulation that requires bypassing the pulmonary filter through a right to left shunt. The discovery of a thrombus trapped in a patent foramen veil, either on in vivo imaging such as echo or a post-mortem via autopsy, is the most compelling evidence for this. And the controversies observed, it's observed in autopsy cases of 25%. The septal anomaly observed in these cases is not associated with any symptoms or signs. So the putative role of PFO as a risk factor for cerebral embolism is in doubt, because the right atrial pressure is more than the left atrial pressure in the normal physiology. It's also doubtful that the thrombotic material originated at DFO. There are so many, the three possible mechanisms that are envisaged are paradoxical embolism, or thrombogenicity, or atrial arrhythmias that may occur in association with the PFO. Though how do we do that? We prevent the thrombus formation, paradoxical embolism, or both. And this is a setting where you should have a concomitant VTE, the large shunt, atrial septal aneurysm, and young age less than usually 60, absence of atherosclerotic risk factors, a high rope score on pulmonary hypertension, and this is a cerebral infarct pattern that is seen in cases. We'll investigate. These rope scores are made to assess the risk of a paradoxical embolism score, and these are the points that is available in the literature. If minimum score is 0 to 3, the risk of PFO is only 0. If 8, 9 to 10, the score, the 99%, there is a chance that there will be a PFO. So this PFO can causally related to the stroke, and the most important, you can see the less than 60, the score increases 2, 3, 4, and 5. So the management of this cryptogenic stroke, and these are the closure devices. US Food and Drug Administration has approved this device on 28th October, Ampladger PFO Closure device. There are all these devices are catheter based techniques, But there are major complications from percutaneous intervention, embolization of the device, malposition of the device, arrhythmias, infection, cardiac perforation, erosion at the site of device, and also atrial fibrillation is a. So whether these are effective or not are studied by case control studies, which have confirmed the association, but these studies are not to be taken seriously because there are a lot of biases in these studies. We have to look at randomized controlled trials. So in a systematic review of 23 case control studies, about one third of discovered PFOs in people with cryptogenic stroke are likely to be incidental, and this probability is sensitive to patient characteristics such as age and the presence of atrial septal. And that means we are trying to identify what are the risk factors. So the causality between this and the stroke is a difficult thing to establish, and a recent meta-analysis that focused on high quality studies found there to be a rather weak association, providing less evidence for causally overall. So meta-analysis of non-randomized studies is a big disappointment because the PFO closure was associated with decreased risk of recurrence of stroke or transient attack in these, but the problem is there are large group differences in the baseline characteristics in follow-up and outcome assessment. So nothing is sacrosanct about this. So the clinical question remains whether PFO plays a role in the pathogenesis of cryptogenic stroke. So three randomized controlled trials, Closure 1, Respect, and PC trials have been conducted to use the transseptal occluding device and a medical management. Both were compared in the Closure, Respect, and the PC trial investigators and the reduced trial. So analysis of the three multi-center randomized trials involving more than 2,000 participants. The trials were conducted less than 60 years or younger and diagnosed by a specialist heart scan. The 1,150 patients were randomized to the device group, where the procedure was performed with Amplatzer device in 2 studies and Starflex device in 1 study. The mean follow-up of all these was 5 years, and the 2 studies were I mean 3 studies were the company sponsored. So the analysis meta-analysis of these studies have shown that PFO closure did not offer any benefit. 3.7% versus 5.2%, and the p-value is not significant. And how many strokes have happened in this 5-year follow-up? 39 in the intervention group and medical therapy in 57. So there are safety issues too, because the atrial fibrillation was found to be 3.8% versus 1%. But then the absence of aneurysmal changes on the interictal septum, limited motion, separation of the septum, primum and secundum, resulting in a small PFO size less than 3 mm. These are the important things you can see. These are the low risk cases. But the high risk cases, the size should be more than 3 mm, the presence of atrial septal aneurysm, which you can see here, and the hypermobility of the septum during Valsalva maneuver, resulting in a large PFO size. These are the high risk cases. Some patients without a characteristic atrial septal aneurysm also have exaggerated motion of the atrial septum during the Valsalva maneuver, but that is the excursion is more than 10 mm, which you can see at 20 mm, and a large PFO size, which you can see with 5 mm arrow is seen in this diagram. So the defense trial has come subsequent to that meta-analysis, which is an open label trial, and in this 120 patients who are studied, and high risk PFO was identified as PFO with atrial septal aneurysm, hypermobility, and PFO size more than 2 mm. These are the studied, and a 5-year follow-up also has happened subsequent to the respect trial, reduced clinical trial, and these results are also available. So in the current opinion in 2019, they have come out with this comparison, that what is, where do we say, what is the ultimate recommendation for this. And you can see the favors PFO closure. Right now we are favoring the closure, but the numbers needed to treat for this is 29 patients to be treated for 5 years to manage one case. That is the NNT of this. And of course, a random effects meta-analysis of randomized trials compared anticoagulation, antiplatelet medication in patients with cryptogen. Which one you want to give, antiplatelets or anticoagulation? There is no recommendation. Nothing could be established. So what are the safety outcomes? We have already mentioned about the problems of atrial fibrillation, which is a major concern, and that is a problem. So that you keep in mind when you are recommending the closures. So the guidelines were issued The practice guidelines of American Academy of Neurology were reduced in April 2020, and subsequently the guideline synopsis was issued by JAMA in January 2021. And based on these trials, the guideline gives a moderate recommendation for PFO closure in patients younger than 60 years who do not have another identifiable cause of stroke. The guidelines meta-analysis showed an absolute risk reduction in stroke of 3.4% and a numbers needed to treat of 29 at 5 years. Because the patients aged 60 years or older have not been explicitly studied, a recommendation for this group was not made. So now the final few slides. The current recommendations issued by American Academy of Neurology in January 2021: adult patients with history of ischemic stroke or TIA with a patent foramen ovale and embolic nature. The major recommendations and ratings are: in patients being considered for PFO closure, clinicians should ensure alternative mechanisms of stroke have been ruled out. To look for atrial fibrillation, clinicians must perform a baseline electrocardiogram, which is a strong recommendation. For those at high risk of AF, prolonged monitoring for at least 28 days is recommended. That is a moderate recommendation with good quality of evidence. And if patients with PFO and no other etiology for stroke, clinicians should counsel that having a PFO is common. That is difficult to determine with certainty whether patients PFO caused their stroke. The PFO closure probably reduces recurrent stroke risk in selected young patients lesser than 60 years with an embolic appearing infarction. In patients who opt to receive medical therapy alone without PFO closure, clinicians may recommend whether an antiplatelet medication such as aspirin or anticoagulation or direct thrombin inhibitors and Novaks. This is a weak recommendation, and which one to prefer is not known. The algorithm says ischemic stroke likely in a patient 18 to 60 years old, PFO with which is confirmed, extensive search for other possible sources. If they are likely, go this pathway, but you calculate the rope score and atrial septal aneurysm, large interatrial shunt, concurrent thromboembolism as is shown in the diagram. Yes, device closure plus antiplatelets. If they are not there, it is medical treatment. That as on today, so the key points: PFO closure results in a meaningful absolute risk reduction of recurrent stroke in well-selected cryptogenic stroke patients of what is the effect size? 0.6% per year. The PFO is identified in healthy adults also. This point has to be emphasized always. Sorry. And PFO closure carries a small risk of major procedural complications and atrial fibrillation. In patients that have an indication for long-term anticoagulation, it is unclear if PFO closure provides further benefit for stroke prevention. PFO-related stroke that do not undergo closure, anticoagulation may be superior to antiplatelet therapy, but further investigation is warranted. Lastly, what is the EBM-based recommendations? Before PFO closure, a thorough evaluation to be performed to rule out alternative mechanisms of stroke level B. Patients with a higher risk alternative mechanisms for stroke identified, clinicians should not routinely recommend PFO closure level B. Clinicians should counsel the patients that having PFO is common. It occurs in about 1 in 4 adults in the general population. It is difficult to determine with certainty whether their PFO caused their stroke. That PFO closure probably reduces recurrent stroke risk in select patients. In patients younger than 60 years with a PFO, embolic aperic infarct, and no other mechanism of stroke identified, clinicians may recommend closure following a discussion of the potential benefits. That is, absolute recurrent stroke risk reduction is 3.54% at 5 years, and risks, that is peri-procedural complications rate of 3.9%, increased absolute rate of non-peri-procedural atrial fibrillation 0.33% per year. It's a level C recommendation. In patients who opt to receive medical therapy alone without closure, clinicians may recommend an antiplatelet medication such as aspirin or anticoagulation. I have two cases, and unfortunately both of them had problems. So thank you very much for your patient hearing.
Thank you, sir. Thank you for your wonderful talk. And still 1 minute is left. We can take one or two questions.
You can invite the questions from the audience also, Dr. Biman. Anyone, there are lots of people in the panel, so anyone who wishes to ask the question may please kindly ask Dr. Vineet or Dr. Gorthi, please. Dr. Gorthi?
Yes, please.
So if I may ask a question to this kickstart, because we don't have too much time, but what is your take on deciding between single, dual antiplatelet versus anticoagulation? Because a recent BMJ review, which includes now what patients' preferences are, there were concerns whether you should prefer anticoagulation or dual antiplatelet therapy, or would you choose single antiplatelet in some patients. So what are your key points on that?
My point is that these are minor strokes usually, so they are TIAs, minor strokes. I treat with dual antiplatelets for 21 days with a loading dose of clopidogrel in the beginning and continue one of them after 21 days for one antiplatelet agent. If there are septal aneurysm and high risk cases, then we should ask closure.
Can I ask a
Can I
question,
ask a
Joe?
question?
Yes,
Uh,
ma'am.
Thank you so much. As usual, a great talk. So, with PFO closures, one of the things which came out is that there may be atrial fibrillation later, and these patients may need anticoagulation. Would you support that statement that many a time, although the closure studies lately have all said more evidence in favor of closure in terms of being much more safer, but do you also share the concern that the intervention trials may actually lead to occurrence of atrial fibrillation?
I do have the concern about it because I looked at the confidence intervals in the recent the defense trial, which is very wide, and it's giving rise to the indecision in our mind that whether to opt for it because atrial fibrillation is a
Dr.
real
Gorthi, can I
complication.
ask a question now? Now, when you see a youngish, like 20-year-old with a PFO and with a thrombophilic state as well, so there's a protein C, protein S deficiency predisposing them to thromboembolism and to DVT. So that I think is a real tough thing because then you have to probably anticoagulate these patients as it is for life. So what is your take on PFO closure in such a situation? Because obviously the risk of the PFO contributing to a stroke is very high, when they have, because they are likely to get venous thrombosis, and then with the PFO, there's going to be more embolism.
I'll sit with my cardiologist colleague and do that agitated saline test and see the dimension of the shunt which is happening there. And if it is large and more than 20 bubbles are passing, then I'll definitely go for a closure. If it is very small and the shunt fraction is very small, then actually I think I will reserve because it's not very sure that we are going to help by closing that.
Okay, thank you very much, Dr. Biman. With your permission, may I kindly close the session?
Thank you very much, Dr.
Thank
Padma.
you, both the speakers and the
Dr.
chairpersons, for
Noel,
a
Dr. Padma.
wonderful session. I now request Suhas to take over for the next.